for participating in Florida Supportive Housing Coalition's training on how to use Medicaid housing waiver services. We have quite an audience here, more than I expected, so I'm really pleased that people understand the importance of this and trying to learn a little bit more of how we can do this. I just wanted to take an opportunity to thank our sponsors that helped us put this together, and that includes Aetna and their behavioral health partner, Beacon. We also have Magellan Complete Care, Stay Well, Simply, and did I get everybody? I think I got everybody that have participated as a sponsor in this so that we could put this together. So thank you all sponsors. Have appreciated the time working with you and hope we can perform to your expectations and to be able to provide the training that you think is necessary to get this thing moving along a little bit better than maybe we have in the past. I'm going to share my screen with you. What we will do is go over a little bit. I wanted to at least let you know who we are. Florida Supportive Housing Coalition is a statewide organization. We've been operating since around 2001. We were finally incorporated in 2006. And the main reason why we developed the Florida Supportive Housing Coalition is that we realized that even though affordable housing was being developed and projects were going up, there really wasn't an opportunity and access for people that had disabilities or for those that were experiencing homelessness. So a group of very dedicated individuals that were developing housing said, wait a minute, we need to make sure that we focus on people with special needs and those experiencing housing. So that was how the coalition was developed. The coalition consists of multiple organizations, including developers and operators of supported housing, service providers, COCs, continuums of care, homeless coalitions. We have other coalitions, or maybe what you call associations, like Florida Behavioral Health Association, Developmental Disability Rights of Florida, that also have an interest in developing housing. So we include any stakeholders whose goal is to improve the access of supported housing for people with disabilities and for people that are experiencing homelessness. And you can see on the slide what we consider are our special needs populations in terms of what we are trying to do. And basically, I mean, I don't want to go over the slide, but you can see what our vision is. We really believe that supported housing, when done right and with the appropriate wraparound services, is a best practice for people who are in recovery and are able to be in independent housing with the wraparound services for them. And having been involved with mental health for many years, many of you may know me from my previous role with Florida Council for Community Mental Health. I sat on the board with Florida Supportive Housing Coalition for many years. And so when I retired from the council and they asked me to take over this position, it was something I was really excited to do. And I will tell you, I thought mental health was complex in terms of rating all the services and all the other things that community mental health centers do and do very well. Housing was a new thing for me. You talk about complexities and braiding funding from federal, state, local governments for both the development and for the services. It was a crash course for me, but at this point, it's amazing to me when I see some of the openings of people's projects that they've done, and they start bringing in individuals for the first time that may have been chronically homeless for a long time, and you hand them a set of keys. It's just amazing to see. Just overwhelming to them and sometimes overwhelming to me to see their face and to realize that they actually have some control over their lives a little bit and can, in a sense, lock their door, close their refrigerator, go to the bathroom in peace, and those kinds of things. So I hope that we are able to expand support housing a little bit through this training and be able to help more and more individuals that are ready to live independently with the correct wraparound services. I'm going to go over the agenda a little bit just to let you know what's going on today. And it is a 2-day training. The first slide is the agenda for today. And we're going to start off with a kickoff from Anna Cleveland from ACA. I will tell you that without ACA, we would not have this waiver. The waiver was put into statute in 2016. It took ACA about 3 years to work through the federal requirements to get this waiver approved. And I have to give them a lot of credit. They stuck in there between presidents and changing in Medicaid philosophy. And I think many rewrites of what the waiver services were going to be and how they were going to be funded and all that kind of stuff. So really without ACA's help in this, we would not be where we are. So a lot of shout out for ACA. Following Anna is going to be Carol Nathis. She is with Staywell. And Carol has also been really involved in this housing waiver since I think before inception. She helped us work it through with ACA and the rewrites of the services and all that kind of stuff. So Carol has been kind of there in terms of plugging along and keeping this thing going. So it'd be interesting to hear from the plan side what they see in terms of the housing waiver and how that's helping them with the individuals that they serve as well. Following that, we have Shannon Nasworth, who is our past president of Florida Support Housing Coalition and has many, many years experience of developing and managing housing. And she's going to talk about different types of housing out there and provide a little bit more background of what supported housing is from some of the other housing that you may hear about or may be familiar with in your local communities. And then following that is Kevin Marone from Bully. Many of you know Bully Centers. They've been operating supported housing for many, many years. And Kevin has been instrumental in implementing the housing waiver services in ACA Area 5. And he's going to give us a little background of what those services are, how they've been using it, and how possibly you can use them to expand your ability to do supported housing for individuals with special needs, those with serious mental illness and substance abuse. And I'm gonna go ahead and turn it over to Anna at this point. Anna has, as I said, worked for ACA for 2 years in the role of the housing waiver itself. She has been instrumental in working with me in terms of developing the services and how those services will be rolled out to the providers. And I know she works a lot with the plans as well, helping to answer any questions and keeping this thing kind of moving along into the pilots. And I'll let her talk about the pilots a little bit. Prior to Anna coming over to the Medicaid policy unit, she worked a disability determination person with the SSI department and with medically needy. She has a master's degree from Florida State, Yay, Florida State, and public administration. So with that, Anna, I'm going to turn it over to you.
Thank you for that lovely introduction. Yes, I'm excited to be here to talk with all of you guys about kind of the technical stuff of the waiver because the plans have been implementing this and they are doing a great job with all the technicalities. But yes, this was the legislature passed in 2016 for us to seek the federal approval for the waiver. And then while working through that, it was approved by April 2018. And so then we started working on the waiver that would now work to provide housing assistance with people who have severe mental illness or substance use disorders or are homeless or at risk of homeless. Those are, and that they are 21 years of age or older. Those are the requirements outside of being enrolled in the participating health plans. And then this waiver went live on December 1st. So the program has been live a little bit over a year. Next slide, please. And through the goal of the housing assistance waiver is to improve health outcomes, achieve the tenancy stability, and reduce high costs. And so they are getting people into more stable housing and seeing doctors regularly than having to utilize the ER, which may not provide as consistent care as needed for these individuals. And so the participating managed care, there was an application process, and so the health plans that have been participating are Aetna, who's completing in Region 7 only, Magellan Complete Care, Simply, and Stay Well are all participating in Regions 5 and 7. And they are, you can see the requirements for the health plans. There's also an application process that can be viewed on the ACO website. Next slide. The housing pilot has these 4 services that are covered by the waiver: the transitional housing services, tenancy sustaining services, the self-help and peer support services. And there is the option of having a one-time incidental covered to help with costs like first month's rent or utilities, or sorry, not for rent, for help for utilities and those type of costs. But yeah, it does not cover rent. And as we are working through this pilot program, we are working through different performance measures to kind of evaluate how the housing waiver is going. And so we're looking at the number of participants that have achieved housing permanency, the number of participants who days as homelessness has been reduced, the percentage of participants who are with an SUD, the substance use disorder, that are receiving the medication assisted treatment, and then the participants who have an SMI who are compliant with their medication, and then the reduction of the emergency department and inpatient hospital use for people who are participating in the pilot and receiving these other supportive services. And that was all for me, so I'll go ahead and turn it back over to Karen.
Thank you very much, Anna. Yeah, I think certainly understanding this waiver, it is unique in a sense. And one of the things I think that we tried to do in putting the waiver together was to listen to what some of the providers were saying, is that they would like to provide these services, but they didn't fit within the sort of traditional Medicaid, behavioral health care, manual, medically necessary type services. So our attempt here in putting these services together was to be able to expand the benefits and the ability for providers to get funding for services that were a little bit more specific of what's needed to help people that are trying to find or maintain housing, because we realize a lot of these people haven't been in housing for a long period of time, and it takes some skill development and some support to be able to maintain that. So appreciate you taking the time and talking about that a little bit. I'm going to now get ready for our next presentation, and hold on, Carol, I'm going to bring up the agenda. But our next presenter is Carol Matis. I hope, Carol, I pronounced that correctly. Carol is the Vice President of Operations for the SMI program under Staywell. As I said, she's been working with us through this implementation for many years, making this thing work. Carol has, I'm going to say many years of experience, Carol. I don't know if you want me to talk about many of them, but she has the experience of being a social worker. She has operated clinics in other states. She has worked with a lot of Medicaid managed care companies, understands the operations of what it takes to be able to make this happen. She definitely has a passion for helping people that are seriously mentally ill and homeless to recover. She works closely with NAMI, and actually, I think if I remember somewhere along the way, won a NAMI award for all the help that she did. I think, was it Texas or something? I won't, but yeah, she has lots of experience and has been really, really involved with this. And we were hoping that in terms of this, Carol, that you could help explain to the attendees the value that you see in the housing waiver and how you've rolled it out and what you perceive in terms of where we're going with this.
Oh, okay. Hi, everyone, and welcome to this training. This particular training has been a very long path on the part of the 4 health plans that operate this program. And I've been asked today to represent the health plans that are working on this housing assistance program. So much of what I might be saying today is really on behalf of all of us. We have been working very hard for the past year and a half, going on 2 years, in developing our individual programs at each health plan, but also working together nearly every week. So I'm going to start with talking about that. There are 4 health plans that have been awarded this program from ACA. We responded to a request for information, and we were evaluated and approved to add this array of services to our already existing health plan programs. We are all Medicaid health plans already contracted with the state of Florida in the ACA contract. And we have been given the privilege of working on this very innovative strategy, particularly focused on dealing with folks with serious mental illness and substance use disorders. And as all of you know, all health plans have a goal of really getting a person the care that they need, the services that they need, and improve their health and the outcomes of their health. And in order to do that, all 4 health plans are certainly committed to providing a comprehensive strategy, which includes addressing the social determinants of health, which includes assuring that our members have safe, affordable housing to live in, and working to attempt to get that to happen, food on their tables, and looking at what other social needs are a part of the treatment program. So no longer is healthcare just about providing medical services, behavioral services, and pharmacy services, but it's also about finding ways to improve one's health by meeting the needs of their social, environmental situations. So the 4 health plans that are in the program are, as Karen mentioned at the top of the program, Aetna is in Region 7, along with Simply Health Plan, Magellan Health Plan, and Staywell. Staywell is now part of the Sunshine Health, so We were recently acquired this year, so we're making a transition to be called Sunshine Health. But until October of 2021, we'll remain Stay Well. So you know us in this program as Stay Well Health Plan. The 4 plans in Region 7. Region 7 is Orange, Osceola, Brevard, Seminole counties. And those are lined up as how the Medicaid office lines them up in their regions across the state. In Region 3, Region 5, I'm sorry, there are 3 health plans, Magellan, Simply, and Stay Well. And in the participating 3 health plans, we are serving members in Pasco and Pinellas County. If you have read the RFP or the initial request, it is the goal of the state through this CMS waiver to treat this as a pilot and possibly implement this pilot across all of Florida. Right now, it remains in Regions 5 and Region 7, and our 4 health plans have been working very closely together to assure that the pilot is successful. And we have spent a lot of time together over the last year working on issues. So we have currently today collectively over 500 people enrolled in the program, and we did, and Anna did give the enrollment criteria. So they are adults with either an SMI or SUD diagnosis, and they're either homeless or at risk for being homeless. The program is really around providing services, not providing rental assistance or actual housing. The services are intended for us to be able to collaborate with local communities, housing providers, and other entities like property owners and HUD services and community-based providers in order for us to connect the members who enroll in the program to appropriate housing and appropriate services. Most of the members, because they are part of a Medicaid program already, do have access to healthcare through the program, and they might have case management through their treating providers. This program does not replace any of that. What it really does is supplements and adds to the support that these members need in order to focus on their housing needs for this particular service, for the services. And what this whole training about is today is to have the providers on the call, the stakeholders on the call in participating in this conference, understand the specifics about what is supported housing services, what are tenancy services, what is peer support, and what is mobile crisis services, because they are the 4 services that are funded through this program. And we've had a lot of questions over the last year, all 4 health plans, about what does it mean? How do we hire and train our staff to perform these services? And how do we get better at finding treatment, placement, and houses for the members that we serve? And what can you, the health plan, do to assist us in facilitating that? So all 4 health plans have staff assigned to this program. We have case managers who actually work directly with you, the providers, and the members to gain their agreement on being enrolled, and then gain their agreement on being able to participate and have the providers serve them. So the health plans serve as the entities who contract and credential the providers and who pay the providers to provide these 4 services identified. We really think that doing that is going to, really does help to assign housing for folks. I am not sure. I guess I'm still on. I'm not sure what I'm seeing here. I'm going to keep going. We want to talk to you about, the feedback we've gotten over the last year. In December, we celebrated the 1-year milestone. And some of the challenges of the program have been actually in finding members. So we run algorithms within our own databases. We have our staff and providers making referral into the program. The state has allotted 4,000 slots for this program. And as I mentioned, we're at about 500. We have had trouble getting folks to sign up for the program because they're difficult to reach. Of course, with the SMI SUD population, they're always concerned about getting into services and treatments and programs that they might not want to participate in. So in this program, it's really a housing first approach. So we don't require our members to have treatment services or even having a treatment provider. What we do ask of them is to agree to participate with our case managers and the providers in us helping them find a house or a place to live or transitional housing and get them stable in a living environment in the hopes that we can also assist with their treatment needs. But it's not a requirement of the program. And even with that, when we do get a referral, sometimes, as you know, with homeless folks, we know where they are one day, but we're not sure where they are the next. So we try to work with our community providers in giving them easy information on how to access us and our program so that when a member is ready to be referred into the program and will accept it, that is, what we really want to do is act quickly. Another challenge has been providers have been challenged with how do I set up this program, bill for services, continue what I do in addition to this program. And some of our providers have never worked with Medicaid before. So we have developed, each health plan has developed some tools, including one-pagers about the program and a quick reference guide that each of us have produced in order to be able to give you information on how to bill, what services and what they mean, where to go to get a contract with us, application, all of that. And then the criteria that we collectively have developed around the program. So in the hopes with this training today and the additional support, we will have increased capacity to serve more members and more providers interested in either growing the number of referrals they're taking or growing by joining our network. So our network for these treatment services are still open in all the health plans, and we are looking to build capacity in these 2 regions even today. So as you can imagine, another challenge to launching the program has certainly been around the COVID-19 crisis. We originally rolled out the programs, each of us, with the intention that we would be feet on the street, on the ground, looking for members and trying to get them enrolled and connected to the treating providers. Certainly with COVID-19, all of us have been largely telephonic, largely doing videos like this and not able to connect directly with our members. So we are hopeful that as in 2021, as the pandemic hopefully abates some and we have forward thinking in months, that we can get back to really engaging our communities in growing this program. So this training, we are hopeful, will get you prepared and ready for the coming months where we want to really grow and develop the program. So enough about the challenges. I do want to speak briefly about the positives. I can tell you from the Stay Well perspective, and I know from my colleagues and speaking with them, with the other 3 health plans, of the members we are serving, Stay Well specifically has placed about 39 people in a house or a transitional living environment that previously were not able to find affordable, appropriate housing. We have connected these folks to financial resources and other community-based providers, and have partnered with some key providers to really get these significant support services going, like the supported housing and the tenancy housing services, which are so important in keeping anyone that we put in a placement there. We don't require that they be in treatment, as I mentioned, but we are finding with the folks that we are getting into stable housing, they are more amenable to engaging in treatment. So that's a very positive thing. And we go at their pace. So if they say, okay, I'll see a doctor, think about medication, we're looking to connect that. But if they say, no, I'm not quite ready to engage with a group therapy or with a targeted case manager at a community mental health center, we're going to honor that, but continue to try and work them towards a treatment program that's appropriate for them. So that's a real positive, that once the evidence, national best practice and evidence all shows us that we do have the ability to engage members in treatment when they have stable housing. We seem to have some early evidence that that is happening. We also are seeing significant reduction for folks that are in this program. We are seeing significant reduction in ED visits and inpatient admissions and readmissions. And our early data is telling us as much as 50% reduction in these visits. And while the numbers are small, the results really, as we grow and who we enroll, are encouraging. And we really do know that that high touch intervention, that non-judgmental and active participation does really help to improve the engagement of a very difficult population. And the participation of our providers who are community mental health centers, I think on the one side, the training in the next 2 days are really going to help you understand, okay, what do we do with these services? On the other side, though, I think the resources and the availability of getting payment for this kind of treatment service is going to really open up and grow capacity and discussion among community providers as to where are our housing resources and how do we access them. So the other part of this training today will focus on that and give you good insight, because I can tell you all 4 health plans have learned a lot this year about what it takes to provide housing to vulnerable individuals, and how much more difficult it is because they might have a criminal history that keeps them from being put into an apartment, or they might have behaviors that are difficult to manage, or they can't manage independently. So this program really helps us get into the a deeper level of understanding of what those housing needs are for these unique set of individuals.
Well, thank you, Carol. I don't know,
Yes.
was there, was there, let me see if there was anything in the chat room, any questions for you? Nah, I think we're good. We do want to let everybody know that this is being recorded, that people will have an opportunity to hear what you say. It's nice to hear the positive. I think we do realize as we were moving towards this that, you know, it's not science. Everybody knows that it's a small population that generally are the higher users of the services. And if we can reach those individuals and assist in terms of them staying healthier, not needing to go to the ER and stuff, I think that's a great thing. I mean, that's what the national research shows, and it's good to know that Florida is doing that. We're hoping the opportunity to, those performance measures will encourage ACA to move this beyond the 2 pilot areas. So there's several other areas I know in the state that have a lot of affordable housing and are very anxious to be able to have the opportunities to provide these services as well. So it's good to hear that it's demonstrating, I think, what we need to do to be able to get ACA to move forward. And I really appreciate the time you've given us. It really, I mean, one of the things I think is important is that the plans, as well as hopefully providers, are learning that there is a cost offset, a cost benefit to this, and that it really does work, including the housing first model, which you certainly alluded to. So thank you very, very much for your time. I appreciate it. I did want to let everybody know. Go ahead, Carol.
I just wanted to say that there are representatives from all 4 health plans on this conference today. And if you have specific questions about how to access to get an application or needs, Karen will be providing in her documentation of this conference all of our information, but we're happy to also individually share that as we go through.
Let's see, there was one other one in there. I'm looking at some of the questions. One said the barrier to interest and enrollment is in the program is effective and useful. Many affordable household providers have minimum income requirements, basically SSI, which we all know. And how can we mitigate this bottleneck? Carol, I do know you mentioned a little bit earlier in conversation I've had with you that the plans are trying to help out with individuals sometimes in terms of making their rent. And we certainly know the program, as people improve, the access to benefits improves at the same time. So,
well, you know, from a very peripheral level, there is some ability of the health plans through this program to do some incidental assistance, monetary assistance for things like rent deposits and that sort of thing. The program is not designed to provide ongoing financial support by way of making rents or utility payments and that sort of thing. But our case managers, along with the providers contracted in the program, are working very hard to coordinate and access the resources that are available in the programs. And each of the health plans do have some expanded benefits that they list in their programs that do, do sometimes help with the social determinants and financial needs of members. So it's a matter of coordinating and collaborating in where the resource is and matching the member to the resource.
Well, you bring up a good point. One of the things as part of this training, everyone that participated will get a resource manual. And I know one of the questions was to, provide you with links to the different plans and what they're doing. So After this, we want to make sure we get everybody's slides into the resource manual, but it will include everybody's presentations, the slides, a whole list of different resources in the two ACA regions that the pilot is there, and including the links to the plans, including some ideas on where you can maybe find vouchers, how you can find supportive housing or whatever. So that will be available probably next week after we collect everybody's slides and get that all together. So hopefully as we move through this, and at the end, we will be able to supply you enough resources to help you as providers to move forward. So thank you, Carol.
You're
Appreciate your
welcome.
time, and
Thank you.
we'll look forward to seeing you again. Appreciate it. All righty, I'm going to move to our next presentation. I don't even know how to introduce Shannon. She is such a part of my life and such a mentor, but Shannon Nasworth is here to discuss what housing, supportive housing is. She has been a very active developer for special needs housing and housing for homeless. She's a strong advocate. She was, I guess, past president and maybe even founder of Florida Supportive Housing Coalition. So she's been out there advocating for many years. And I will say, because of Shannon and many members of our board, we've been able to actually grow supportive housing. And I know a lot of people think it's not enough, and we're very aware that it isn't enough. But over the many years, we've been able to actually get a definition in statute of who is special needs and who this housing should go to. We have got in statute set aside for at least 10% of the affordable housing funds to go to people with special needs. And Shannon's working constantly on getting that bigger and bigger. And it's working for a Housing Finance Corporation. Even though they're only required to do 10%, technically have definitely over exceeded that because of their commitment to persons with disabling conditions and homelessness. So Shannon, there's probably a lot more that I could say about you, but I will let you brag about yourself a little bit, and thank you for being part of this training.
Well, thank you very much, Karen. That's very, very kind, and you are far too kind, because I, one, did not found the coalition by any stretch, and it has definitely been a team effort, and I cannot say how instrumental you have been to our successes so far. So thank you for everything you've done. I guess I will go ahead and share my screen so that you can all see what I'm going to be talking about. And again, these slides will be available to everyone, so please feel free to, I'm just trying to make sure I do this right. So pardon me for 1 second as I have minor technical glitches, but I will get this right for you yet. All right. This is always fun. Sorry for the challenge. Try it again. Here we go. Okay, hopefully you are looking at my slides. If you're not, please let me know, shoot it in the chat, and I will fix that for you right away. So as you can see here, I'm here to talk about permanent supportive housing. And I will say first and foremost that I'm not a service provider. I'm actually a houser. I joined the Supportive Housing Coalition more years ago than I'm willing to admit, because I started working for an organization that was doing affordable rental housing for adults with developmental disabilities. And I started getting some emails about housing for extremely low income households and persons with special needs, and was very intrigued and got involved. I did not have any special training or understanding about homelessness or persons with disabilities or supportive housing before starting. And in a certain way, I think that was a good thing, because I really just started from scratch, Googling best practices, and was able to learn from the best, because this is a very evidence-based practice that works really, really well and is highly beneficial for the people we're serving, as well as the service providers in the community at large. Ability Housing is an affordable housing developer. We're headquartered in Jacksonville, but we serve Northeast and Central Florida. We currently have 5 apartment communities in Jacksonville, 2 in Central Florida, and a 3rd that just opened up and is leasing up now in Osceola. We are looking to do more housing, and we are also helping other nonprofits develop housing for special needs households. We do contract with other nonprofits to provide support services to our residents, and we have staff that is among the national leaders at providing supportive services to persons who have been homeless and have special needs. They really are very good at what they do, and they work closely with our partners to make sure all of our residents have access to the services they need to be successful. And what Karen asked me to talk about today is what is supportive housing, and because in her conversations, she knows that there are different terms being thrown around and that there's not necessarily always clarity as to exactly what we mean when we say permanent supportive housing. And I think Karen mentioned it, but there will be the option to do question and answer at the end of the presentation. So if you have any questions, please put them in the chat and I will do the best I can to answer all of them. If I'm not able to get to all of them, I promise we will get an answer to you afterwards. So what is permanent supportive housing? There we go. Finally got it to turn. Okay, sorry. So permanent supportive housing. First, I guess it's easiest to say what it is not. It is not transitional housing or bridge housing or a halfway house or anything like that. Permanent supportive housing is permanent, meaning there is no preset time limit as to how long you're allowed to stay in the housing. Doesn't mean you have to live there permanently forever, but it means that you have a lease, a legal lease, and the right to live in that apartment for as long as you choose, provided you're abiding by the lease, just like the rest of us who are renting an apartment. And then supportive because services have to be provided or at least offered to the resident. They do not have to avail themselves of the services, but they have to be offered to the residents. And there are other terms that are being thrown around right now. So I wanted to kind of clarify what is rapid rehousing and affordable housing and things like that as compared to supportive housing. Rapid rehousing is a new intervention last few years that people are using for to help households exit homelessness that do not need the deep end services and the deep affordability of permanent supportive housing. It is the intervention that is the best for the majority of households who are homeless. It is for people who are not going to self-resolve, who maybe just one, short-term assistance and they won't be homeless again, but they don't need the deep end services and supports associated with supportive housing. So it is not short-term rental assistance with support services to help the person access whatever supports they need in the community, get reacclimated into housing, negotiate with the landlord, find a place to live, sign the lease, get their kids re-enrolled in school, find a job, those types of things. But it is not ongoing support services or ongoing rental assistance. Affordable housing is exactly that. And I will say we all need affordable housing. It really means that you have housing you can afford. But when we say the term, usually what we're referring to is housing that has an income restriction associated with it. A government program of some nature helped finance the construction of the property. And in return for that financing, the owner has agreed to limit the residents to certain income limits. Most of the projects that you're probably going to be interacting with have an income limit of 60% of area median income. And the rents are also at the same rate that is affordable. So if it's a property that is limited to 60% area median income, the rents will be limited to rents that are affordable to a household earning 60% area median income. And then there's a lot of talk, especially more recently, about mixed income and mixed use housing. And those are exactly what they say they are. Mixed income is housing that maybe some of the units are affordable, some of the units are market, maybe some of the units are permanent supportive housing, some of the units serve the homeless, and other units are affordable. It really is just whatever, it's where there's not a preset limit as to all of the units being set for one target population or one income group. And then mixed use means different uses. So you could have shops on the first floor and then 3 or 4 stories above it with apartments. That's a mixed use. You have commercial plus residential together. What is permanent supportive housing? So it is, according to SAMHSA's definition, affordable housing with sufficient wraparound supports. It has 4 key elements, and I will go into each of these. Choice, housing and services are functionally separate, integration and rights of tenancy, and flexible, voluntary, and recovery-focused services. So choice is just that. And it doesn't mean unlimited choice. It's choice within the options available to the individual who's being served. But they should be part of the decision-making. They should, as best as possible, try to find out what they would like and then try to meet that. Yes, housing is limited. Affordable housing is very limited. There are limited choices. But if there is more than one option available at that time, they should be part of helping make the decision as to which of the options is best for them. If they live in Orlando and a housing option becomes available in Osceola, they should be part of that conversation as to whether it's appropriate for them to move to Osceola. Or if there is the option to move to a property that is 100% permanent supportive housing, or one that is one apartment in a larger apartment community, which one would they prefer to live in? Which setting is better for their personal needs, wants, and desires? Also, they should be part of the decision if there's going to be a roommate. They shouldn't be assigned to live with somebody. They should be part of knowing who they're going to be living with, if they're going to be living with someone else, and part of the decision-making process. The housing and services are functionally separate is a really key component to the success of permanent supportive housing. I think this is one of the most important parts of the best practices of doing supportive housing. The role of landlord is a much different role of a support provider. And you don't want a landlord trying to be a service provider, and you don't want a service provider trying to be a landlord. Doesn't mean they can't work for the same company. That is done frequently. As I mentioned, we have program staff here at Ability Housing, but they are very functionally different departments within the corporation. The services department is dedicated to meeting the needs of the tenant, and that includes being an advocate for the tenant with the landlord, whether they live at one of our properties or someone else's properties, because not all of the people we provide services to live at a property we own. And then the property management side, their job is to make sure that property is run efficiently for the benefit of the residents in the community. Permanent supportive housing is most successful when it's a three-legged stool. When the tenant, the property manager, and the case managers all work together to make sure that tenant is successful in their housing. But they are clear and distinct roles. You don't want to have the landlord threatening the lease if somebody's not doing what the service provider wants. And you don't want the service provider strong-arming their tenant to pay rent if the landlord isn't meeting their obligation. Those are two different roles, and they really need to work together and in alignment with everybody working towards success, but understanding the roles and responsibilities and making sure that they stay true to those roles and responsibilities. Another key element is integration and the rights of tenancy. We want the housing integrated in the community to the greatest extent possible. We don't want that building over there with those people. We want it to be just a building on the street that anybody walking down the street would want to live in. It's important that the tenants have all the rights and responsibilities of a lease. They should have a lease just like everybody else in the market has the lease. And they should be encouraged to integrate into the community. We have found over the years as we do this, that one of the keys to success for the tenants is as they build natural supports in the community, as they engage with the broader community and become involved, and they find their own support systems that augment and can, benefit the tenant without needing to only rely upon paid for services. It's really important that they feel part of the community. That empowers them to have more control of their living environment and for them to be an active member of the community. It is also very important that they fully understand their obligations with the lease. That is the key component that we personally like to use lease signings really as an educational moment. The property manager can sit with the case manager and the tenant and really walk through the lease and talk about what all the terms mean, what are the responsibilities, what to do if something happens, if something breaks, how to contact property management and ask for it to be fixed, what to do if they have a problem with an on-site staff person or another resident, so that they just understand how to interact with the landlords. Frequently, the people we're serving have been on the streets for a very long time. It's been a long time since they've had a landlord. They might need a little bit of assistance reintegrating into how to fit into that type of relationship. And we view that as really important. And it is the only reason that someone should be kicked out of their housing is if they don't abide by the lease. The services have to be voluntary. They should have to be available, and it is up to the services providers to engage the residents, but the services are not part of the rights of tenancy. The only reason a person is asked to leave the housing is if they violate the lease. Either they don't pay their rent or their behaviors are such that it's too detrimental to the property, like destroying property or threatening someone. Those are the only reasons people should lose their housing. If they don't go to services and they're still being successful in their housing from a landlord perspective, that's fine. We have had service providers over the past that we worked with that had asked us to threaten to kick people out because they weren't going to services. We're not going to do that. If they're not breaking the lease, our relationship with that person is the fact that we're their landlord. We are providing their housing. If they're not violating the lease, one, we have no legal authority to kick them out of their housing, but two, it would be completely inappropriate to do that. It really is up to the service provider to engage the residents successfully so that they want to avail themselves of the services. And candidly, sometimes our residents move in and they don't want services right away. But then when something happens and there is a fear that they might lose their housing or they realize they need some help, if the service provider is just continuously try to engage them, they will take advantage of that opportunity because they don't want to lose their housing and they do want to get better, get access to healthcare, get access to other things. But sometimes it just takes them a little while to trust and believe that this is their housing and to build that relationship with the service provider. And sometimes it's not going to be successful. Hopefully not very often. At Ability Housing, we have a 95% housing stability rate. So 95% of our residents retain stable housing, but sometimes people don't. And when that happens, we do the best we can to facilitate a graceful exit. We try to do it in a way where when they're ready to try again, they can come back and we'll try again with them. But they're just at that moment not able to meet the needs of the lease, and we try again to make it as easy and as graceful an exit for them as possible. But if we have to, we will evict, and we have done that. Not always a permanent supportive housing residence. Frequently, it is for non-payment of rent. That is the most usual reason we would choose to evict somebody from our housing, but there could be other reasons as well. And if they do threaten one of our staff or another resident, we cannot allow that on the site. Everybody has to have the right to safety. Permanent supportive housing can be site-based or scattered site, and Ability Housing does both. So we, as I mentioned, own 8 apartment communities in Northeast and Central Florida. Those are site-based permanent supportive housing. Not all of the units are permanent supportive housing. At all of our properties, we have a mix of general affordable housing, units that are set aside for formerly homeless households, and units that are permanent supportive housing that have the deep rental assistance and the wraparound supports to help the residents be successful. We also master lease over 100 units in the community. Through a HUD homeless grant, we are able to house over 100 people who are chronically homeless, have been on the streets for many, many years, have co-occurring disorders and lots of challenges and barriers. But we're able to master lease over 100 units so that they can access market housing. And then we also provide them those wraparound supports so they can be successful. For some people, the site-based is a better environment. For other people, the scattered site is a better environment. And sometimes one is the only option available, and that's what you've got to go with. But all options should be on the table as to how you create supportive housing. One of the biggest barriers, and you guys already know all this, is affordability. And it is a barrier for everyone. We have an affordable housing crisis in this country that is unequaled in our history, candidly. Wages have not kept up with housing costs for decades, and we are all feeling the pressure. And when you have market failures like that, when the system is broken and we're not keeping up with the need, the pressure gets greater the lower the income of the household is. And the people we're talking about, the people we serve, are the people living on SSI who have very limited incomes. I do not have a magic wand for you. I wish I could tell you go here and you will find all the housing that is affordable that you need. It doesn't exist, but there are ways to create it. And Ability Housing has worked with others to create these. So first is tenant-based rental assistance. And basically most people think of that as a Section 8 voucher. There are other types. we, can provide those as well through some of our homeless grants and different types of resources. Sometimes there's communities that have tenant-based rental assistance through different federal programs. But the most common that people are familiar with is what used to be called the Section 8 voucher and is now called the Housing Choice Voucher. I would encourage you to make sure every one of your participants is on the Public Housing Authority's wait list for a voucher. That is the most secure way to get long-term, permanent, affordable housing, is for them to get a voucher and then be able to retain that for as long as they need that affordability. And for the people we serve frequently, that will be possibly for the rest of their life. And that's okay. That's why these resources exist, is to serve the most vulnerable and those most in need. If your tenant is not on the Housing Authority's wait list, they definitely need to find out, when does the wait list open? What is the process? How do I get on the list? Because it's very important. There also possibly could be some preferences and other things that the Housing Authority is instituting because they're trying to help the community address homelessness. They may have a preference for persons who are homeless. They may have a preference for persons with disabilities. So you should definitely make sure you're communicating with the Housing Authority and understanding what the options are that are available and how you can get all of your people onto their wait lists. And I say wait lists because they are not going to be moving in right away. Another type of rental assistance is project-based. And those are properties where usually they're privately owned, sometimes they're owned by the Housing Authority, and there's a rental assistance contract with HUD where the tenant pays a portion of their income, no more than 30% for their rent, and then HUD pays the balance of the rent so that the housing is affordable to the tenants. Ability Housing owns some of those and is lucky enough that we're going to be getting a couple more contracts with HUD for some of those here in Jacksonville. But it is a very strong resource, and one where you can try to find out who are the private owners of HUD assisted properties in your community. Get to know those property managers, build a relationship with them. Through those relationships, they may be willing to accept your tenants when a unit becomes available and they're eligible for that unit. And that is done on a landlord by landlord basis. There is not a master list or anything like that. It really is by learning about each of those landlords individually. Frequently, the property management company will be the same company across multiple properties. So if you build a relationship with one property management company, you can actually be building a relationship with a myriad of properties across the community. But it is, again, another way to provide deeply affordable housing, and it is in very short supply. The third type of rental assistance is sponsor-based, which is very similar to project-based, but it isn't tied to the project, it's tied to the owner. And Ability Housing has these through our homeless assistance grants. We have a myriad of properties here in Jacksonville, and we can use our rental assistance at any one of those properties. The rental assistance is tied to Ability Housing in our program, not to the physical property. The property has to pass all the inspections and quality standards and those types of things, but the assistance itself is not tied to that unit. It is tied to Ability Housing so that we can provide it to the family or individual who's most in need. And then very important to supportive housing is housing-focused supportive housing case management services. And I'm not going to go into all of the different types of services because I know that's on the agenda later in the training, but they are very integral to the success of supportive housing, making sure that all of the providers are well-trained and well-versed on the best practices and the evidence-based practices that they, engage. That first and foremost, from a supportive housing perspective, that it's housing focused. How do I help you get into housing? How do I help you maintain your housing? But also, how do we help you access other services? How do we help you access behavioral and primary health care, job development, other community resources, other services in the community? But the case management itself is not about the health care of the individual. It's about the housing supports and their housing stability. And then you link with others to get them to the health care that they need. And one thing that we have found to be incredibly successful is peer support. Certified peer support specialists have been tremendously successful for our residents. In fact, we have paid for some of our residents to be certified so that they can work for other companies and provide peer support services. It A case manager is very important and it is a wonderful relationship, but it is not the same as having somebody who has walked in your shoes, been where you've been, and can help you hold yourself accountable to your own goals and your own plan for achieving those goals. And peer support specialists are incredibly adept at this, and they've been tremendously wonderful to work with. All of our residents really, really appreciate all of the support and services that they get through the peer supports. And I believe this was referenced earlier, but I will say permanent supportive housing is really cost effective. Ability Housing participated with this Florida Housing Finance Corporation, Department of Children and Families, and Agency for Healthcare Administration and others in a pilot in 3 spots around Florida to assess what is the cost benefit of providing permanent supportive housing to high utilizers of crisis services. Ability Housing led the Duval County site, and we were the first to complete our pilot. We worked with the community, identified the most at-risk individuals. We had 92 people participate in the pilot, and we hired another firm to do a cost benefit analysis, comparing the 2 years before the person moved into their housing with the 2 years after. What was the cost to the various systems of care? And including the cost of the housing and the services, it was 30% less expensive for our community to provide permanent supportive housing than it was to maintain those individuals as homeless before they moved into the housing. We've also been working with United Healthcare here in Jacksonville on a pilot for supportive housing for high utilizers. Jacksonville is one of the areas that has one of the higher utilizations of emergency departments, and they're trying to find ways to help people get into stable healthcare as opposed to crisis healthcare. And so while it's not part of the ACA pilot for the waiver, it is a different pilot that we've been doing here, and it has been really beneficial. United Healthcare is doing this because they're saving money. In the end, they may be using some of their discretionary company resources to provide rental assistance, but they're doing it because they're saving a great deal of money on the other end, and their profits are higher when the people are stably housed and not utilizing those crisis health services. It's been really beneficial and very, very helpful. The individual's quality of life is far better than it was prior, and the healthcare system is able to provide those stabilization and primary care services as opposed to continuously being in crisis mode and only dealing with crises. And this is from the Corporation for Supportive Housing, which is another resource that I strongly encourage people to go to their website if they want to learn more about supportive housing, csh.org, Corporation for Supportive Housing. They are the national expert on supportive housing, and they have published a myriad of information on the research related to supportive housing. And this is their definition for supportive housing. And they have been advocating for this at the federal level for several years, decades at this point, because they know how effective it is. They know that it really works for the individuals who are in need of the housing. They know that it's better for the healthcare system. They know that it's better for the case managers and the service providers. If the person has a stable place to live, they are able to use those services to their full extent. When I talk with people who don't understand supportive housing, who aren't in the services world, who aren't in the housing world, who are just concerned citizens, when you talk about it, if you think of Maslow's hierarchy, it is the foundational need. It's shelter and food. You have to have those 2 things. Otherwise, you are only going to obsess about getting those 2 things. So if you can give somebody a place to live, then they can take care of themselves. They can avail themselves of the services. No matter how great a case manager is, if somebody's spending their entire day worrying about where they're going to sleep tonight, that case manager cannot engage with them in the same way that they could if the person knew that they were home, that they were safe, that they could lock the door, they have a refrigerator, they have control of their environment, they're safe. I'm going to start rambling, so I think I'll stop there. First, I'm going to find out, are there any questions so far? And because I want to make sure that as I talk, I'm answering and directing this where people would most like to learn. So are there any questions so far? I'm going to assume that's a no because I can't hear anything.
Hi, Shannon. Yes, there are some questions.
Okay.
So the first one is related to questions about security deposit. Property owners don't like waiting 60 days or more for payment. Sometimes a family member can pay it sooner if they could be paid back via the waiver instead, but the waiver can't allow for that. Is that correct?
So I'll be very honest, that is a Medicaid question. And as I said, I am a housing provider and not a service provider or a Medicaid provider. I do know there's a great deal of flexibility within the federal regulations about Medicaid. I have met with people at the federal level about Medicaid repeatedly. And the one thing and the only thing at the federal level that it cannot pay for is the actual rent payment itself. I don't know if somebody can loan the tenant the security deposit and then the tenant be reimbursed for that security deposit. From a common sense perspective, I would think it would be a logical thing to permit, because yes, most landlords are not going to wait 60 days for a security deposit. You need to be working with that landlord and making sure they are getting everything they need as quickly as they can. And you definitely need to make sure they're getting their rent check on time. You cannot be late with any of the application, the security deposit, and the rent check. You need to have those right away. And then the landlord will be a happy landlord. But I don't know the technicalities. I see Karen has come on, so maybe you know the answer to that one, Karen.
I do know the answer in terms of Medicaid dollars themselves. The federal government does not allow the matching dollars that the state pays in to be used for rental assistance. There is some ability to use a one-time assistance dollars, but the actual Medicaid dollar itself cannot be used. Now, in some states, and I don't know if Florida plans are, do any of the Florida plans are doing this or not, but states, some of the plans can actually pay it out of their dollars if it's not a direct Medicaid payment, so to speak. So, I mean, in a sense, if there's some profits on one side, or once it's no longer recognized as a Medicaid dollar, then those dollars could be used as a resource to help for rent, but it can't be recognized as a direct payment from Medicaid.
But it can be for security deposits. At the federal level, you are allowed to use Medicaid dollars for the security deposit. It is literally the rent check itself that can't be paid for.
That's
There are
correct.
move-in expenses, all sorts of things that can be Medicaid dollars are eligible for at the federal level. I don't know about the timing thing of why you wouldn't be able to reimburse a resident for an eligible expense if a family member loaned it to them and they paid the security deposit, but then needed to repay that loan to their family member. But again, that is a state level policy issue, because again, at the federal level, completely eligible use of resources. They, I can say, and I will say now that it's afternoon on the 20th of January with the new administration, that this administration will be mirroring what the Obama administration was doing with regards to promoting housing and promoting choice and promoting permanent supportive housing. It is a policy priority. They recognize the benefits. They recognize the savings to the healthcare system. You know, the last one, I don't know, it wasn't the last because we now have new secretaries, but one of the more recent secretaries of Medicaid, of CMS, had talked about wishing rent itself was a Medicaid eligible expense, because they realize it will be less expensive for me if people stop cycling through the hospital and other crisis services and had a place to live. So at the federal level, I believe they're going to return to really trying to encourage as much flexibility with regards to the use of the resources so we can get people into housing.
Yeah, and I think, Shannon, some states have asked for a waiver to be able to use resources. Florida has not, but in a sense, the housing waiver that we're talking about, the plans do have up to $1,000 of incidental dollars that they are allowed to use for, you know, one-time rent or utilities, or as you say, deposits and those kind of things. It's the ongoing payment of rent that is sort of the sticking point.
Yeah, and it is the hardest part. I mean, people need an affordable place to live. It's the barrier we're all facing. And until we figure out how to fix that problem, the problem itself is not going to go away. But, you know, I will encourage everybody. And again, I will say, I am not a Medicaid biller. I am not a service provider. I have staff who are service providers. I am a houser. But I have worked enough with Supportive Housing Coalition and partners around the state and the country on these topics. And we are working and have been working for, I guess, about 18 months with United Health, identifying their highest need persons and providing them with permanent supportive housing. And it is doable. It can be done. People need to lean in on taking the big picture view of approving the services, making sure that the preventative nature of supportive housing services, it may not be easy to identify the direct medical benefit of making sure somebody has supportive housing case management, but the health outcomes are proven to always be better and the costs are proven to always be lower if people have access to those supportive housing services. So, everybody leaning in on interpreting things as liberally as they're allowed within the rules. I'm not advocating breaking any rules, to make sure everything is as eligible as possible. I know with DCF and some others as well, it's not Medicaid dollars, but there are dollars that can be used for training to help people with life skills, learning how to make a bed, learning how to use a kitchen. Well, they need sheets to make a bed. So we can buy sheets because that's part of the training equipment. And we can leave the sheets with the person because now they're used and nobody else can use them. And so we get creative in finding ways to help pay for the incidentals so that the individuals have the housing they need and the stuff in the housing that they need. But I'm sorry, I don't know the answer about the 60-day ability to repay something that was loaned to the individual. I just don't know that answer.
There are other questions in the chat. Can you see them, Shannon?
No, I'm afraid I cannot.
Okay. Let's see where we want to start. One of the questions are, what are the points of entry where people can be referred to permanent supportive housing or rapid rehousing within your group?
So for ability housing itself, it really is two ways. If somebody is homeless, they should be going through the community's homeless coordinated entry system. In Central Florida, that would be the Homeless Services Network, HSN, out of Orlando, but they serve the Central Florida area. And so if they are homeless, that is how we take our referrals for permanent supportive housing units. If not, then it is really through each individual property and just getting with the landlord. I will say that, we have always had an interest in helping to make sure these pilots are as successful as possible. We are not in the Tampa Bay area. We can't help there, but we are interested in finding out how we can do the best we can to assist with making sure that individuals have access to the housing with a landlord who understands supportive housing and even being the supportive housing provider. What we don't have is a magic wand where we can provide free apartments. We have to have a way to access rental assistance. We can provide units that are below market rents, so the rental assistance is lower, but we can't provide units that are affordable at SSI rents. So we are more than happy to meet with any plan and talk about ways to come up with those resources so the residents have reliable rental assistance. And then we can be the landlord and the service provider. Once we learn how to do that with Medicaid, we don't currently do that. But we don't have a magic wand either. We wish we did, but we just don't. It's unfortunate.
Another question is, how can you refer someone who doesn't have a case manager? I guess in a way, the question is, could somebody contact Ability Housing, a parent or something, and say, I want you to, possibly look at whether this individual fits into your housing model? Do you help them then connect with the local service providers and case managers?
We have done that. I mean, we get those calls all the time. A parent will call and, sometimes it's a child with a developmental disability and the parent is getting older and they've realized that their child has never been in the system and they're terrified that they're going to pass away and their child is not going to have any supports. And what do? We do tell them candidly to first, to get involved with the system and let the system, whatever the system is that the individual most fit in. We can help with service provider references, but candidly, anybody who's involved with the waiver pilot should know who those service providers are already. We're not encouraging people to call Ability Housing, so we can tell them to call Aspire or insert other service provider here. But we do get those calls all the time. And when we do the best we can to help them within the community they're located, find a service provider who's best fit for them. Again, resources are limited. So people are usually looking for a place to live and we do the best we can but we don't have that magic wand, although I keep looking for it every day.
I'm not sure if this is one you could answer, and I may help you if you can't, but the question is, so my understanding is that there's a daily bed rate paid for interventions or crisis services. How is this different from rent? And what is the time limit for those crisis interventions? 30, 60, 90 days?
So again, this is more on the Medicaid side than the housing side of it. And this is not my area of expertise. I would suggest asking these questions of Susan when she's on later, because she is pro at these. But you know, some of those are either services that are provided in a licensed facility or by a licensed provider. And rent isn't that. Rent is just rent. I'm not saying that we shouldn't come up with ways to make rent eligible if we are willing to pay for the housing component of residential therapy, or the housing component of insert, you know, ALF or insert whatever here. We should be willing to pay for the housing component of supportive housing, but right now it's not permitted.
Yeah, and I'm not sure some of that isn't, when you talk about more traditional Medicaid services, some have limits in terms of how many of those services can be provided, you know, within a month, within a day, those kinds of things. So that may be some of the Medicaid limitations that you may be thinking about. With the housing waiver benefits, generally there's not a lot of limitations starting into it. What you will be receiving in the resource manual is from each plan. They have provided me what they're calling their billing tips that goes through each one of the different services and talks about what the limits are of that, whether it requires an authorization or not. But the whole idea of these services is to make them as available as necessary to keep somebody maintaining housing. And having worked with the plans, if you need authorization for more of these services, I'm sure they see the cost benefits of keeping somebody housed. And I think the workaround is probably maybe a little bit easier than you have encountered with the more traditional case management services.
And that is my understanding as well. I've heard a lot about that. And, you know, I also serve on the state's council on homelessness, and ACA is one of the members. And again, not a service provider, but I would try to chime in for the Supportive Housing Coalition members who are service providers and the challenges with supportive housing services and Medicaid billing. And with this waiver, you know, there's a lot of flexibility, and everybody really does want to show that it's successful. We know that it works. We know supportive housing is better for the person. It's better for the community, and it's, you know, a higher and better use of limited resources by a long shot. So being as flexible as possible, you know, from the service provider side, the conversations I've had with them about some of these things is concerns about, you know, not being authorized to provide the services, but the person's in the housing and they have to provide the services, but they're not getting reimbursed, in that endless loop of concern, and the timing of the getting reimbursed, and those types of things, as making as much as possible not needing prior authorization, or at least having as much flexibility as possible. And then just working with somebody if someone does need more peer support specialists or case management services because they just need that, or they're going to lose their housing and return to the streets or wherever they were. You know, that's a worse outcome for everybody. So flexibility is really, really important. And, you know, in talking with the service providers, you know, they're also working with the plans and talking, you know, they need to talk with the plans as well and really understand where the plans can be flexible and what the plans are willing to do. So I think it's awesome, Karen, that you're going to be able to provide that information, because I think that will make it a lot easier for several service providers to really be able to do as much as possible to make the individuals in this pilot successful, because it is very important for all of us that we show how beneficial this is for everybody.
And I think the plans are starting to recognize that. I have one more question in here. They would like to learn more about the Medicaid waiver, and hopefully over the next day, this day and tomorrow, you'll have a better understanding of that. But the question is really, are persons diagnosed with serious mental illness not eligible for the waiver? The legislation very clearly states that anybody that meets the serious mentally ill definition, and we can make sure you get the of that, but I don't think it's any different than what most people are familiar with. But it's those individuals and persons who are experiencing homelessness and at risk of homelessness. And I know ACA, the waiver uses the definition of homelessness and at risk of homelessness used by the federal government. And so that's the one they use in terms of whether that population is eligible. But anybody that is seriously mentally ill and within the 2 ACA regions, which is ACA Area 7, which comprises Orange, Brevard, Osceola, and Seminole County, or in Area 5, which is Pasco and Pinellas, would be eligible to be in the Housing Waiver Services Program.
Yes, and I think as we're all learning more about how this pilot is working and the lessons learned, I think the one thing that I personally, as a board member of the Supportive Housing Coalition and as the CEO of Ability Housing, who is deeply committed and passionate about this mission, is, housing is the barrier. Finding ways to fund the rental assistance is the thing that we need to come up with, and getting creative and looking cross silos. So if this bucket can't do it, but there's huge savings in this bucket, how do we work with this bucket who's seeing the benefits and have them share in providing the rental assistance? And also, the plans themselves, just really looking at their bottom line. United has been wonderful to work with, but they're also, not doing this out of pure altruism. This is a bottom line, saving money, higher profits scenario. And they are providing rental assistance, not through Medicaid dollars, but they are directly funding rental assistance to make sure that the people have a stable place to live, because they're seeing such monumental reductions in the use of crisis services that it's a profit maker for them. They just do better. And most importantly, the individuals do better. Their health is so improved. It's been remarkable to work with these individuals and see, even just a few days later, but 3, 6, 12 months later, really fundamentally different health trajectory.
Well, thank you, Shannon. Again, I want to remind everybody that Shannon's presentation is being recorded, and you'll have an opportunity to go back and listen, because I know she covered a lot of information about supported housing. And Shannon, I think there's programs that you're developing in Orange, and you're expanding in Orange County and surrounding counties. So hopefully as you grow, the waiver grows, and we can get this thing, expanded to other counties. I'm sure you would love to have it in Jacksonville and Duval County at this point. And I know people in Tampa are biting at the bullet. So keep your fingers crossed, and we'll keep working on this. But I wanted to thank you for your time and all your information and expertise. It's very well appreciated.
No, absolutely. And again, I hope I provided what everybody was hoping to get, just kind of what is supportive housing and what isn't supportive housing. I will say I've had multiple conversations with people about the need for housing, and then 20 minutes into the conversation, I realized we're not exactly talking about the same thing. So I think terminology is important. I will also say that one of the things I've learned is I've learned how to translate, because I'll be in a conversation literally with somebody from DCF and Florida Housing Finance, and they're using the same terms, and I'll realize they're talking about 2 totally different things. So, trying to help each other learn more. I will also say I've been very impressed with our state housing finance agency. They have really embraced the need to create more supportive housing. Their resources are limited. So, if anybody wants to know what to do about more affordable housing, tell your legislator to fund affordable housing. We need more resources. We have a state housing finance authority who's willing to work with us to try and create more, but we need the resources for them to have to deploy. But I do really think, the plans for putting this together, and Karen, you for organizing all of this. And I hope I provided the information you wanted people to walk away with. And I hope I provided it in a way that people were understanding. But if your questions come up afterwards and, they need information, please let me know, and I will do everything I can to help everybody understand as much as possible, because this is very important that this waiver pilot be successful. So I thank you for putting all of this together.
Yeah, well, thank you very much. And we'll definitely be able to go back and look at whatever questions we get and get them answered and out to everybody, and ways to be able to contact Ability Housing and see what kind of developments and stuff you have that might be available to people in ACA Region 7. So thank you again for your time.
Absolutely. And you will get to meet Joe later. I think he's tomorrow. So he can also answer more questions about the services side of this. He is a national pro on this. So you'll get to meet him.
Definitely.
Thanks.
Thank you very much.
All right. Bye.
Bye-bye. Well, we're doing pretty good on time, everybody. I appreciate the good questions that you asked and keep them coming as we go on. If we can't get them all answered today, we'll certainly go back and address those down the road. If we have some time, maybe at the end of the day, we will do that. Or if we have time later on tomorrow, we will also try to address everybody's questions. So thank you. See, is Kevin on? Is Kevin there? I'm going to do Kevin's introduction. Kevin, you got logged in?
Yes.
There you
yes,
go.
I'm here, so whenever.
There he is. Okay, well, thank you very much. This is Kevin Arone. He is a licensed mental health counselor and he works for Bully Center. He's been at Bully Center many years. And I think a lot of you as attendees may know Bully Centers. They've been very instrumental in developing supportive housing for persons with mental illness for many, many years. Kind of was one of the initial groups that launched housing, and let Kevin talk about how many units and everything he has, but he has been instrumental in helping us get this waiver started. Many times I'll get an email from somebody and say, well, what should we do with this service, or what service do we need, or whatever, and Kevin's always the one that is able to address that. What do they say? You've been working with individuals with disabilities for over 40 years. You don't look that old, Kevin.
No, not that long.
But he
25
has been, working both in terms of, I think, maybe even as a peer specialist, sometime working directly with clients and also overseeing the housing for a lot of people that are getting services through Bully. And I'm assuming that you also provide housing for other people that are not necessarily clients of Bully Center. So just appreciate your time here. You're one of my experts, my go-to people, and you have lots of information about that. I know Kevin says he is, a faculty at Webster University, which is teaching master's level courses on mental health counseling. He was selected as the Faculty of the Year in 2014, and currently he's working on his MBA in Business and Leadership. A bit of a stretch from a mental health counselor, but I remember going through my training. That was one of the things that we were taught as social workers, that if we were going to go into more than just counseling, that having that business experience is a big asset. So hope that works out for you. And Kevin, I know you're a passionate person with this, and every time we talk about it, you just strengthen my feelings that we're doing the right thing. So I'm going to turn this over to Kevin. It's all yours.
Thank you so much, Karen. Great. Thank you for the great introduction. So happy to be here. I remember when I first started hearing about the housing waiver pilot, it did create some excitement for me because it really coincides with the mission of the work of Bully Centers over the past 50 years. So I'm going to kind of, my goal today is to cover the various pilot codes, but I'm going to start out with just sort of a little orientation to Bully Centers and how we got evolved and started. And then, I'll kind of roll into how that carries forward through with these various codes. So I'm going to go ahead and share my screen here so that we can get started on the presentation. And I've got my contact information here on the first slide. I am the Chief Operating Officer for Bully Centers. We serve Pinellas County in relationship to our housing services, but we do have employment services in Pasco County, Manatee County, Sarasota County, but our housing services are exclusive to Pinellas County. Here's my contact numbers and email and our website if there's any, if you'd like to get in contact with me directly with any questions after the training. So a little bit about BOLI. We began in 1970. We actually we're celebrating our 50 years in the community just this past year. It's unfortunate that's during a major pandemic, but that's okay. We'll get through and find ways to celebrate when things are safer out there. But we've been providing treatment, rehabilitation, housing, and employment services for individuals in recovery for 50 years. So a little historical perspective, you know, we were founded in 1970 initially as a 20-bed halfway house for men with mental illnesses. In 1979, Pinellas County, primarily BOLI, was chosen as one of 3 sites in the state to develop a deinstitutionalization project. Through this project, we were able to expand from those initial 20 beds to 200 beds. By 1984, BOLI had purchased its first residential facility. And by 1994, all of our residential facilities had been converted from rental to agency-owned property. So although we began initially in the space of providing residential treatment, residential services, what we learned during those initial 20 years is that people do recover when you provide them a safe place to manage their mental illness. And they do reach a point where they are thriving and striving for further levels of independence. So during the 80s and 90s, BOLI began focusing on higher levels of rehabilitation and independence. We began purchasing and leasing apartment complexes, apartment buildings. We implemented supervised apartment programs, which are no longer in existence because they stopped funding that platform, which is ultimately involved with what we're really known for today, which is our supportive housing programs. So over the past 30 years, we've developed over 1,000 units of affordable housing for vulnerable populations. And we are a small housing authority. So we, in addition to our project-based housing units, we manage over 750 community-based vouchers. This includes HOPWA vouchers, Shelter Plus Care vouchers, mainstream vouchers, and some other local city vouchers. So today, BOLI centers and our affiliate corporations that we've developed as part of our network own 53 properties in Pinellas County, and we lease 5 service centers, including vocational youth services. Now, when we think about the core services that BOLI Centers provides, so in addition to our housing, our focus is on recovery and rehabilitation. So we have outpatient and day services. So that provides group activities, rehabilitative group activities, outpatient counseling, outpatient psychiatry. We have our mental health residential treatment programs, which are funded through state DCF dollars. We have our supported housing program, which is the supported housing services that are tied to project-based units known as HUD 811s, which we developed in the 1980s, 90s into the early 2000s, where we were successful with this program through HUD in developing affordable housing for persons with mental health disabilities. This was really how we got started in the world of supported housing, because at that time, HUD actually funded construction for projects. So we were successful in developing and building about 19 units, 19 different apartment complexes throughout Pinellas County to provide supported housing services for those with severe and persistent mental illness. Supported living is our scattered site program. So these are the supported housing services, the wraparound support services to people that live in the community with private landlords. So this program helps people find landlords and then provide services to them in the community to help them be successful in that housing. Also, everything I have highlighted in yellow on this sheet here are the programs at BOLI that we are actively using the Medicaid waiver pilot program for. So we have 3 distinct program areas where we have implemented waiver services and pilot services. We also do have a Florida Assertive Community Treatment Team. We've operated that since May of 2000, although we don't bill pilot services because that is funded through a Medicaid bundled rate. The FACT team does provide services that are in line with the supported housing services and pilot services that are part of this project. Our other area is homeless services. So we have become quite significantly grown in this area over the last 20 years. We're actively involved in the continuum of care here through the Pinellas Homeless Leadership Alliance. We operate 2 safe havens, which are low demand facilities for chronically homeless men and women that need intensive services. It's a low demand model. Just to get them off the streets, sort of bridged housing until we can get them into permanent supportive housing. And then we have almost 400 units of permanent supportive housing for individuals and families with chronic mental health issues and chronic homelessness. So homeless services has been an area of significant growth, unfortunately, because of the high levels of homelessness in our state and in Pinellas County. But this is an area where our partnership with Florida Housing Finance, as well as local funders through Pinellas County Health and Human Services, have been instrumental in being able to continue to develop affordable housing for special populations since the HUD 811 program was discontinued in the early 2000s. This has been an area where BOLI has been able to continue to develop affordable housing for this homeless population. We also have veteran services and then as well as employment and youth services. Shannon mentioned this in her presentation, and I'm going to talk a little bit about it, but that's sort of a landlord versus service provider role, and BOLI does sit in both seats, and so I'm going to talk a little bit about the importance of separating those, as Shannon alluded to in her presentation earlier, because we are a housing authority. We have a housing department that manages the leases for all of our project-based units as well as our voucher programs. And we are also an ADA consultant really throughout the state, throughout the country. Our Executive Vice President of Housing Development, Jack Humberg, is an expert in ADA and accessibility and provides a lot of consultation to ensuring that housing is being considering those disabilities in mind. So in 2020, BOLI centers served a little over 3,000 individuals and families in our various housing and services program. This is just a sort of a little pictorial just to kind of give you an idea you know, of the properties that we develop. You know, we've become very good at this. We've done anything from rehabilitation projects where it might be a boarded up property to new construction, which a lot of the pictures you see here on this page are new construction projects. We integrate well into the community. We typically don't build projects larger than 30, 40 units. So we try to fit in with the architectural styles of the community so that, and we developed a strong relationship with the neighborhood associations, which has allowed for our projects to have a good reputation, even though we might be serving people with high and intensive needs. I know there'll be a question and answer period at the end of the presentation, so I'll be ready for that. But if anyone has a dire question in the meantime, feel free to put that question in, and I'll pay attention to my chat box here and make sure that there are not any urgent questions that come up. So I'm going to talk a little bit about our supportive housing programs. And so we have our residential safe haven programs, which in these programs, we're predominantly using the incidental and transitional housing pilot codes here, because these are people that are not permanently housed yet and are working towards permanent housing. So that's where the transitional services and potentially any available incidental services would be targeted for. In our supported housing programs, which is the HUD 811 programs, we really use almost all the codes except for the incidental, because they're already housed. So we are in full array of providing pilot services there. And our permanent supportive housing, which is the same as supportive housing, but again, just for the chronically homeless individuals. So our services look very similar across the names of our programs, but they have separate and distinct names for us to differentiate, mostly through a funding source or through service delivery model. Like supportive living is our scattered site community-based services. And then our Florida Assertive Community Treatment Team. So, you know, doing this kind of work is complicated. It often requires partnerships with a lot of different funding sources in order to be able to make things happen. We like to call it at BOLI our stool. I think Shannon might have mentioned this earlier in her talk as well, but for housing to be stable and maintain itself over time, you need to make sure that you can first develop and build affordable housing. So that's one leg of the stool. You must be able to make it affordable for the populations that we're serving to live there. You have to make sure that you have the appropriate services wrapped around the individual while they're there. Any of those pieces are not in place, then you don't have affordable, sustainable housing and supports. This slide's here just to, you know, illustrate a topic we talk a lot about at BOLI centers, and Shannon mentioned it as well. We call it our separation of church and state, because it's important, if you are going to be both a landlord, housing provider, as well as a service provider, that you have a clear separation of roles and services, that the landlord is carrying out one part and the service provider is carrying out another. So we've had to spend a lot of time and work to, you know, fine tune this process and ensure that the service provider staff are not being landlords and that the landlord's peoples are not being service providers. It's can be challenging, but you know, it can be done, and when it's done well, it can be very successful. So we're really sort of balancing that clinical support with the rental agreement, the requirements of being housed and following a lease. That's kind of what we're talking about here. And so one thing I thought I would bring up next is, excuse me, is we kind of took a look at the top 5 housing issues for BOLI centers. So the types of things that cause clients, tenants, the greatest challenges and put their housing at most risk. And so this is a list of those 5 things. So not necessarily in a particular order, but this is, they're close to being in ranked order. But number 1, rent collection issues. So clients falling behind in their rent, not paying their rent. This could be because they lost income and they didn't provide housing with appropriate documentation of their loss of income, or it could simply be because they made poor choices and spent their money in other places. Illegal activities is another problem that we do have. I mean, we are working with people that have extensive histories, problems with drugs and alcohol, issues like that. They're vulnerable populations, so they oftentimes become, you know, prey to the community as well. And so things that we end up dealing with are drug dealing issues, prostitution issues, you know, people taking over someone's unit and them not knowing how to get them out, and just sort of illegal activity going on the property. Hoarding behavior. So sometimes when you're working with people with severe mental illness, they do have problems with keeping places, not storing items and collecting items. So hoarding behavior is a common problem that we have to deal with, like the picture you see there on the bottom left. Damage and unsafe living environment. If we're not in there regularly, providing services and inspecting and providing encouragement, support, and coaching and teaching, units can get out of control and get to the point where they're uninhabitable. So these are common issues that we have to continuously manage and deal with. And then the last one is aggressive and violent behavior. Sometimes when you add substance use, alcohol use, people onto a project that have mental illnesses, living together, learning how to socialize and how to get along properly with others, that can sometimes lead to bad behaviors, poor behaviors that we have to manage and deal with as well. Now, how we deal with those can be complex. And I'm going to separate this, since we talked about the separation of church and state. I want to separate this from the housing landlord interventions from the clinical interventions where we would use our pilot codes. So our typical housing and landlord interventions are things like repayment agreements. So when someone's gotten behind in their rent, we have ways to work with them on getting back on track and making small payments to catch up their balance. Constant lease education, lease re-education. We have our landlords have property meetings with the staff, as well as sometimes they have them on property with the clients as well. There are landlord interventions like 3-day notices and 10-day notices, which is the process for letting them know that they need to correct a behavior, whether it's a rent issue or whether it's a violation of their lease issue, like illegal activities, unwanted, unauthorized guests, properties, complaints on property. We have the landlord provides notices, formal written notices to the tenant to let them know, hey, this has got to change. If it doesn't change, we could move forward with an eviction process and your housing could be at risk. Housing also provides safety inspections, eviction proceedings. Sometimes we have to involve law enforcement interventions. We've partnered with law enforcement when there's been frequent drug activity or community violence, and we've had our offices used as substations. We've had to hire security patrol units to provide additional protection and security on our units in the after hours, in the evenings and weekends. And then we do have an appeal hearing process where if any tenant feels that an action taken against them related to the landlord side is incorrect, they have the option to appeal that decision. So those are landlord interventions, things that our housing department would do. Now, when we get to the behavioral and clinical interventions, these are the types of things that that fit very well into the Medicaid waiver pilot program, because here we're talking about routine home visits so that we can catch those early warning signs. We're talking about flexible service delivery based on the person's needs, relationship building, so engagement. A lot of the work that we have to do is about engagement because there are trust issues and psychosis, paranoia, anger, a whole bunch of things that are often sometimes barriers to forming strong therapeutic relationships. We also have to model effective behavior. So we have to help them see how they can better handle situations in the future. So there's a lot of teaching, skill building. We use a lot of motivational interviewing to help them, make better decisions and choices regarding their behavior. In addition to the housing staff, the clinical staff also have property meetings. They have house meetings to talk about issues going on the property. They also do some group activities as well to engage and develop social relationships. We do rely on our other behavioral health and healthcare providers to refer people for treatment that's outside of the scope of what we provide. We do apartment inspections, but not the same kind that the landlord would do. Our service staff are really doing the inspections to kind of help them know what's in their lease and help them avoid housing interventions. So these inspections are more like educational and coaching to help them learn how they need to maintain their apartment and keep them in good condition. So we also have a process at BOLI called Crisis Intervention Team. So several times a month, we meet as a group. This is the one time where the landlord and the service providers do come together collectively for a meeting, and the housing department will outline their concerns and lease violations, and then the program staff will respond with how they were going to try and provide an intervention to help avoid further action being taken and housing being put at risk. So it's important that coordinating meetings and keeping communication going is critical. In programs like supportive living, where we're working with private landlords, this is just as important, right? So we must engage and have these relationships with our community landlords. We must develop important relationships with them if we're going to retain their apartments as future housing options for our clients. So whether it's BOLI as a landlord or whether we're working with private landlords, the relationships between service providers and landlords is critical. So this kind of leads into the housing assistance waiver program. And as we go through these codes, you'll see how everything that I just talked about are things that BOLI Centers has been working on and managing for over 40 years. So you'll start to see as we go through these pilot codes, how in line these codes are with the problems, behaviors, and interventions that I've just outlined. They're in sync, and it leads to why I was so excited by this pilot, because for the first time, Medicaid is starting to recognize that, hey, there are some specialized services that are really geared towards keeping people sustainably housed, keeping people out of crisis systems, hospitals, jails, and these services work. We've seen the effect of these services, but we need to keep the data coming so that we can prove that these services do save money. We know through lots of research in past studies that they are effective. We know Florida Assertive Community Treatment ACT teams are effective. There's 40 years of research on that, and we know that supportive housing is effective. So I'm excited that we have this pilot. It's been a great opportunity to work with Aetna, Magellan, Simply, and Stay Well at a whole nother level than we've worked at in the past. It's been a great experience so far. So when we're talking about the covered services for this housing assistance pilots, this is an outline of those services. So we were talking about our transitional housing services, which are designed to prepare and support the transition into permanent housing. And we'll talk about each of these in a little detail in a few minutes. The tenancy sustaining services, which are all the services that support an individual in becoming a successful tenant. This is probably the bulk of the services being provided is under the tenancy sustaining services, at least for BOLI centers, because we have so many people already housed that need these services to be successful. The other code is the mobile crisis management. So this is the opportunity of providing immediate on-site de-escalation of crises and issues. These are the types of services that can potentially avoid some sort of criminal activity or behavior, or even a psychiatric emergency, if we can provide early crisis support and intervention. The next one is our self-help peer support group. It's critical that peer support services are a part of this process. BOLI has been working and hiring peer specialists within our agency for over 20 years. So we've always identified the value of having persons that in recovery as full members of our staff and service team. Their experience and their ability to connect with clients is unique and differentiates significantly from other staff, and a very powerful component to any service delivery model. All of these service programs at BOLI centers have some sort of peer support staff or role integrated and part of the team. And so it's great to see that in addition to valuing the need for these services, but actually providing a mechanism for billing for these services as well. And then the last one here is those one-time incidental payments and moving expenses for people that are trying to get housed that might need some brief financial assistance. So the first one, the transitional housing services, this is where you're working with somebody on tenant screening, doing a housing assessment, developing a housing plan, searching for housing, the application process, identifying resources for how they're going to go pay for those expenses, and ensuring that their living environment is safe and ready for move-in. So a lot of these services for BOLI centers are kind of done before they come to us, because they come to us and we're housing them. But we do have our supportive living program where the staff here are working to helping people find housing in the community. So they do use the transitional housing services in those programs, and in some of our residential programs, those staff, those case management staff, are working on getting people permanently housed as well, and would use these transitional housing service codes. Now, I think Shannon might have mentioned this, alluded to this several times. As we all know, we do have that affordable housing crisis going on. It's probably one of the biggest barriers to this code is just the lack of affordable housing, but it's wonderful that Medicaid is providing an opportunity to reimburse and provide payment for the time and effort that it takes to find housing and get people housed, because it's an extremely time-intensive process to find and connect people to affordable housing. Tenant sustaining services. So this is the bulk of the pilot in my view. This is where the work is done to legitimately supported housing. This is where you're identifying issues, behaviors, interventions that could jeopardize housing. This is what's covering the education and training with clients on the roles, rights, and responsibilities for them as a tenant, coaching and helping them establish key relationships with their landlord. And again, at BOLI, that includes both landlords that we work with out in the community, as well as their landlord that they have at BOLI. So even though we're a landlord, the client will be assigned a property manager that they will need to have a good communication with and relationship with. So the service staff that are billing these pilot codes are working with the client on the importance of having good communication and relationship with their property manager. This is also where we're providing services and assistance in managing disputes. This could be neighbor disputes, or it could be disputes with things related to violations of their lease or misunderstandings about their rent, anything related to that. And then this is also where we would provide advocacy linked to community resources that help them to prevent eviction. So, oftentimes we give lots of opportunities. Eviction is really our last ditched effort. We don't want anyone to get evicted from our housing. We're in the business of helping people get out of the cycle of homelessness. We're not in the business of putting people back into homelessness. However, there are times where we to quote Star Trek, where the needs of the many outweigh the needs of the few. When behaviors and problems on a property begin to interfere with the health and stability of others around them, there may be a time where eviction is the only recourse when all interventions that we've attempted have been unsuccessful. When we reach that point, if we reach that point, for us, it's still important that they not lose future opportunities to access HUD-funded housing. So oftentimes when the decision has made to move forward with an eviction, we will often engage the client about doing to give up their unit on their own recourse. If they do that, then it avoids having that eviction on their permanent record. Sometimes people will engage in that option, and sometimes they won't, but we like to always provide it, because even though they may not be in a place where it's worked out today, we don't want them to be blocked from services later down the future if they're in a better position down the road. Mobile crisis management is the next code. At BOLI, we have an on-call system, and we have several licensed clinical staff that are available for interventions for any crises that occur on our property. And so this is great that this is a part of the waiver, because it is an essential piece to being successful in permanent supportive housing and running supported housing programs, because these services really can help divert a poor outcome and keep people from getting people either access to the care that they need or avoiding outcomes like incarceration or hospitalization. The self-help peer support, I talked earlier about the importance of this. So this is a person-centered service. This is really for those staff members of ours that are persons in recovery. So people that have experienced mental health issues and have received services in the past, and now they're at a point in recovery where they are giving back and using their experiences and their ability to recover and providing those services and supports to people in our programs. It's extremely valuable service, and we couldn't imagine operating our programs without peer support. And the final pilot code is the incidental coverage. This is has specific to each of the managed care plans. They each have their own guidelines as far as their incidentals, but these are one-time incidentals to help with cash assistance in getting people into housing, deposits. I think there was a discussion earlier with Shannon's presentation about rent. That is one exclusion. You can't pay actual rent, but you can pay incidentals and deposits to get people set up and into housing. So this is valuable for those that need that in order to be successful in finding and getting into housing. It's not a code that we use a lot at BOLI, simply because of the way we serve clients. Since they come through coordinated entry of our homeless system, or they're on the wait list for our 811 projects, there is not typically a need for incidental coverage. It looks like I do have a question that's come in, so I'll pause for a moment and read the question here. It says, how does one get defined as having SMI, SUD according to their Medicaid provider? How do they prove they are someone who deserves to be enrolled in this waiver program if they don't receive SSI or just Medicaid so far? So typically how this is done is we would get releases signed by the individual where they've received care or services, and we would request that a form is filled out that from their medical provider or licensed person that can verify that they are experiencing a severe mental illness. So this is typically a simple form that says that they have a serious mental illness and that interferes with their ability to function and live. They don't have to be on SSI. They just have to have someone that can vouch or verify that, for the program. So I hope that answers that question. We can also verify that through a clinical records, a psychiatric evaluation, or any document that verifies that. If someone has never been seen by someone or has been never been diagnosed because maybe they've been refusing treatment or services, you can use a licensed person. Oftentimes I'll use my street outreach person that is trained and has the ability to diagnose. If they believe the person has a serious mental illness and there's no record of that, then they can provide that verification documentation, and then we can work towards getting a diagnosis once they're brought into housing. So I'm happy to answer any follow-up questions to that, later in the question answer period. I really just have kind of one more slide to close this section out. And I really just sort of wanted to tie in what I've seen as the benefits of supported housing services, this housing assistance pilot, and then how that just sort of relates to social determinants of health, which is such a key topic today. We know that when you provide the appropriate, when you make housing affordable and you provide the appropriate services to someone, you're going to have better outcomes, and it's going to be cheaper, more cost effective, and long term. We've seen decreased use of inpatient and criminal justice facilities when these types of services are in place for people. And that's because of the hands-on interventions and education. This is not a passive model. This is not, let's wait and see if they show up for their appointment. Supportive housing is on site. It's bringing services to them, even when they are at a stage in their treatment and their recovery where they may be pre-contemplative or resistant towards housing intervention. This is an engagement model. So it's about how to engage, provide, develop rapport and relationships, and bring those hands-on interventions and educations to the person rather than wait for a crisis or wait for them to show up for an appointment. It has improved access to healthcare, right? Because now we have somebody developing that relationship, working with them doing regular assessments, identifying healthcare issues, and getting them connected to primary medical care. It's where otherwise these individuals may not access care at all. So these pilot codes and the work of supportive housing addresses the social determinants of health on all levels: economics, education, health and healthcare, social and community, as well as those intrinsic factors. It also improves communications with the community, and in this particular pilot, it has really improved the communications with the various managed care plans that have been part of this. I'm not saying that we haven't had relationships in the past, but this pilot has brought special relationships because we're meeting regularly with each of the plans, and we're discussing cases one by one and identifying barriers and working on breaking down those barriers. So it's been a fantastic process for my staff, and I hope for the MMAs as well. We are seeing decreased homelessness with supportive housing. It's shown through evidence, and we see it here at BOLI centers by our long-term stability. So people that maintain their housing, for years and years. About 90% of clients that come into BOLI's supportive housing will maintain that housing after 5 years. So we know this works. We know that this decreases homelessness. We know this increases housing stability. And then the last one is the reason it works is because we have addressed global functioning, we've addressed holistic care and support systems, and we've identified those things that help people to be sustainable into the future. And so I couldn't be more excited to be here today to talk a little bit about this. I'm excited to see where this pilot continues and moves forward into the future. Hopefully it expands further. I'm open now to any additional questions that people might have. And it looks like we've got one here. Is the housing first philosophy practiced at Boley Properties? Absolutely. We are a housing first organization long before the term housing first even originated and got coined. We are no barrier, low barrier to housing. There's very little things that will not allow someone to be housed at Boley. It's critical, it's foundational to our mission and philosophy. And so it's a great question. Thank you for asking. And then the next question is, if housing and services are integrated into one building, how does lease format differ from independent tenancy? So our housing department is located in our main administrative building. So all of our housing staff are there, and our service staff are actually in most cases on site at the apartment complexes. So we have offices at most of our apartment complexes. There may be a few of our older buildings that do not have an office, and in those cases, a staff at a nearby facility would be the one assigned to that location and would still go into the apartments and provide those services. So there's a separate leadership, separate division, even at the high level. As chief operating officer, I'm over the church, the services side of the organization, and Gary McMath, our CEO, and Jack Humberg are over the state, the housing landlord side. So even at the high level leadership level, we try to maintain that to ensure that we're following, the importance of both functions within the organization. Number 4, does an agency program need to be able to bill Medicaid to use this pilot program? I'm looking for more information on how to implement the PSH pilot program at my agency to assist housing clients with SUD, SPMI. Well, we've been providing these services for many, many years before this pilot existed. But the problem is most of the services that we've learned that we were providing were not covered by Medicaid. Medicaid provided reimbursement for psychosocial rehabilitation, which is a service modality that we do use at Boley centers. But oftentimes when it comes to supported housing, we find that the services that take up most of the staff's time do not necessarily fit into the psychosocial rehab requirements, from a utilization review perspective. It is really these codes that we just outlined that is the bulk of the work of a supported housing. So do you need be in the pilot to provide the services? No, but the pilot provides the compensation, the reimbursement through Medicaid for providing these services. So it is an extreme benefit and help to any organization's revenue source to be able to get payment for these services that otherwise might not get paid for.
Yeah, let me interject in here, Kevin. I know from talking with other people, we have agencies that have been providing housing services that are not Medicaid providers at all. Mm-hmm. And the question has come from several of them, to be able to use these benefits, do they need to be a Medicaid provider? And yes, they do. However, there are different ways to become a Medicaid provider. The plans can work with you individually, that you can become a Medicaid provider just for these housing waiver benefits. You don't have to become a full-blown treatment provider, the whole continuum of care and all that, and some of the other regulations and requirements that come to if you're being a traditional kind of Medicaid provider. So there's ways to be a Medicaid provider, but yes, to get reimbursed for these particular services, you would need to be a Medicaid provider. And I would encourage anybody that's thinking of doing this to contact their plans. Each plan has a way of bringing you in as a Medicaid provider to their network. So it is kind of individualized. There's a way to get through the ACA Medicaid procedures, and they can probably help you with that. Or certainly we can follow up with some information from ACA in terms of in the resource manual, how and whom you may want to connect if you're interested in becoming a Medicaid provider for the housing waiver benefits.
Yeah, that's great. Thanks, Karen. And I know they need more providers because I'm on calls with them regularly, and it's a desperate need. So, certainly get with them if you're not in a position already. It may not be as difficult as you might think. And so certainly get the information because it's important.
I saw in the chat, there's another question about that you have to be a Medicaid enrollee to get these services within the pilot. And the question was how to get a client involved in Medicaid. I guess if you're a non-Medicaid provider, you're going to need to connect them with your local community mental health center that's involved with the plan and possibly work with them or like I say, if you don't have a case manager, if you got clients there that you think qualify, I would certainly contact the local service provider in your area and see if they qualify for those services. I don't know this question. One of the things is, could you get these services through a doctor? I'm going to say no to that. I'm not going to say 100%, but as far as I know, you have to be a Medicaid managed care plan to be a qualified plan to reimburse for these services. So I'm not sure a doctor alone without, being a Medicaid managed care provider would be able to provide these services and bill for them. But I will follow up with ACA and see, if that's accurate, but that's kind of where I'm going with right now.
Right.
Did
Okay.
we get any new ones in there, Kevin, while we were talking?
Looks like we got one more that came through. For
Okay.
instance, our agency is a Medicaid provider biller for our counseling and psychiatry services, but not our housing services. How does our housing team access the PSH waiver resources to house clients we find through outreach? Yeah, I would contact each of the plans representative to get enrolled. Correct, Karen?
Yeah, I mean, the 4 plans that we had early on in the slide, Aetna is only a qualified Medicaid provider for the housing waiver services in Area 7. I do not believe they're qualified in 5, but Magellan Complete Care, Staywell, which operates the big carve out, the SMI program, is involved in the waiver, Staywell, Simply, and Magellan. So if you're in Area 5, that would be the 3. And each one has access to this. And to be honest with you, I mean, you may already have eligible clients that are in one of these 3 or 4 plans. So technically, it's just letting the plan know that you're interested in getting involved in the housing waiver benefit piece of it. And as you well know, one of the things that they have to do is reach out to the client and make sure the client is interested in receiving these benefits specifically. And there's some clarification with that, but the clients have to agree that they want to be enrolled in the housing waiver program and need to understand that they're not losing anything, but they're actually gaining by being in the program. But if you're involved with those 3 or 4 plans already, it's just a matter of talking to them and saying you have clients available to them that meet the definitions for people that need to be in the waiver.
And just to kind of reinforce for us at BOLI how important and valuable I find these codes to be in line with our mission and work of supported housing, that these codes have become a regular new permanent way for all of my programs to record the various services that we provide, whether they're in one of the 4 MMAs or not, because I find that this data is going to be extremely valuable, even internally here. So now any services in my supportive housing programs are being captured and kept based on these codes. And then those that are not in the MMAs, it just doesn't get, obviously it doesn't get billed, but it's extremely valuable information. Whereas before, these services that we were providing maybe were just kind of getting lumped into one broad code. And so, you know, I couldn't speak to more about how the breakout of these 4 or 5 codes fit the kind of the philosophies and purpose of supported housing.
Let me ask you something, Kevin, in terms of applying these benefits. Like, do you have set aside staff that kind of, that's their main thing, so that, you know, they're geared to do the housing benefit services specifically and bill for them? Or are you letting your other sort of treatment case managers, peer specialists participate as well?
We have a small billing team that is really responsible for this. You know, it starts in our electronic health records, setting up their financial guarantors. In other words, who their billable insurance is, and then we have a partnership with our IT department that helps to develop all the code pathways to ensure that proper services are billed to the appropriate plans and care. So it's definitely not something done at the service staff level. It is kind of a separate and unique expertise that I think you have to have. You know, that billing expertise is kind of unique.
Mm-hmm. So there's some development deciding, you know, okay, we want to get involved with this and learn a little bit more about how to bill for them, how to separate them maybe from other more traditional case management services, and possibly do some training with the staff that, in a sense, will actually be delivering and billing for these particular codes. So,
yeah, that's correct. I mean, probably where the service staff do play a role is they're the ones closest to the client. So they're usually the first ones to know that, you know, they got Medicaid, maybe they've been waiting for disability determination and they just got Medicaid, or maybe they switched from one plan to the next. So the staff are usually the first one to probably know that because they're seeing the client. And so that is helpful when we get that information to then be able to implement that quicker in the system. But the actual work is a separate area. Looks like we have another question here. Do you need to have a mental or substance abuse problem to access the Medicaid housing waiver benefits?
yes.
So yes, I mean, that's the essence of this pilot. It's to provide those waiver services for persons with severe mental illness.
Yeah, and just, I mean, the question was just to have a mental illness or not. It necessarily, the legislation that passed and the waiver requires that it needs to be somebody that's diagnosed with serious mental illness. On the substance abuse side, it's more general than that. But in terms of being in the housing waiver, somebody would have to be considered diagnosed as SMI to qualify. And mainly because the housing waiver was looking at the most difficult and in terms of needing housing and the extra services that would hopefully help that population, those individuals get into housing. So that is statutorily required, and the state waiver that gave us this pilot indicates that as well. All righty. Well, I don't see any other questions. I know you may be over a little early. I'm sure people aren't necessarily upset about that. We do apologize. When we put this together, we didn't realize it was inaugural day, and we apologize for taking you away from maybe some of those events, but I do want to say that in our way, we see this as an inaugural, more launching of the housing waiver. And so certainly appreciate your time and being with us. I want to thank all the providers and presenters that were in today. I do want to apologize. This was kind of our test. This is the first time Florida Support Housing Coalition has actually done this large of a virtual training. So we learned a little bit today. You were sort of our test candidates. I know there was some difficulties with people signing in. I do want to clarify that if you had signed in earlier and had gotten the code and then put that code in and then got out and got back in, you will get another code tomorrow. So when you sign back in, don't use the code that you had today, but look in your inbox and your email or on your phone for the new code, because you will need that. And every time you go out and go back in, you'll need to use a new code. So it's not like a assigned code to you, it's a code produced when you actually log in. And I think sometime today we were having some problems with that because people had been in and out of that. If you hear from people from your agency that they couldn't log in, they didn't get a code, I have a call after this with a organization that's helping us do this. And so we will definitely try to fix that for tomorrow. So if you hear from them, please let them know to not give up, give us another opportunity to make this work for them tomorrow. And then remind everybody, there is a recording of this. If you talk to some of your fellow staff members and they said they couldn't get in, we will have a recording of all of this today and of tomorrow. And my expectation is we'll be able to have that recording out to you next week along with resource material. And we will use the questions today and questions tomorrow to build that resource manual in terms of what links and things that you may need that will further answer your questions. So we hope to keep expanding this. As I say, we have another shot at virtual tomorrow, and hopefully that will go better. And I also want to let everybody know that we usually do a face-to-face annual conference every year on supported housing where we can even dig into these issues deeper. We postponed it in the fall, but we actually have our May training that will be our annual supportive housing training coming up. And so everybody that is on this training, and I have your emails, I guarantee you will get an email from me with a save the date and more information on that. So look for that. It's, I believe, May 19th and May 20th of this coming year. And we will certainly have some breakout sessions and some keynotes and everything that will hit on a lot of the topics that came up today and a lot of the questions that you asked. We will build workshops around that as well. Let's see, we had another question. Is there another question? Let me see. Let's see any, did I miss something, Karen? Kathy? Okay, I don't see anything else. You will definitely get a copy of everybody's slides. And that helped explain some of the things that we just talked into. Oh, here's the question. Okay, so we are a homeless shelter that provides crisis intervention and case management. We are all set up to bill Medicaid. Essentially, we could be screening for these managed care plan providers and bill for peer support specialists incorporated. Definitely, I mean, if you qualify as a Medicaid provider, then I would get in touch with depending in what area, the qualified plans in terms of working with them. And, we do have the transitional housing services that certainly we would hope that people could help in terms of assisting people getting ready to go into supportive housing, and also help to work with the supportive housing providers in the area to get people into supported housing. So I would encourage you definitely to do it. Peer support, you'll hear more about that tomorrow afternoon. And it is one of the keys to the housing services. I think a lot of times we are not using peer support specialist enough. And I think what we were trying to build with that was to give, an opportunity, because we know how well that works with individuals that are serious mentally ill, to work with somebody that has that experience. And you may be able to see that they also may be able to take some of the load off the case managers in terms of some of the daily visits, some of the skill training, and those kinds of things that possibly you don't need your case managers to do. So get in touch with the plans in your area and see what they need from you to be able to get you into the housing waiver program. What do we got? What is the experience for the property owner landlord to receive these payments? As far as the property owner landlord, we're really talking about people that are permanent supportive housing providers that know how to manage those properties and take individuals in that are special needs under this particular waiver of seriously mentally ill or experiencing homelessness. Obviously, you would have to be a Medicaid provider. You can't just be a landlord or tenant. These are really the wraparound services to property owners and stuff to help them. So if you're not a Medicaid provider yourself and just operating supported housing, you need to find out who your Medicaid providers are in your area that can help put the wraparound services for you in terms of being able to access these things. Delays or difficulties or inspections, HUD requirements. The only HUD involvement in this is the definition of homelessness or experiencing homelessness. This is purely a state program that Medicaid has received a waiver to deliver. So HUD is not involved with this. Whatever requirements oversee the housing waiver are from CMS, the federal government that oversees Medicare and Medicaid. So HUD is not involved in this in terms of accessing these services specifically. Let's see, anything else? Well, thank you. I got a nice thank you from individuals, and certainly want to thank you for taking the time. And I look forward to seeing you tomorrow and getting the information that you need. So we didn't answer anything today, or you have a question that comes up after this, feel free to drop it into the Q&A tomorrow, and we'll get back to it if we can't do it. After each individual's presentation, we'll have a wrap up at the end, and hopefully we'll be able to answer everybody's questions. And if there's nothing else, again, thank you for your time. I hope you get to enjoy your evening. And I did want to do one cleanup. Tomorrow, remember, when you sign back in, if you log in for tomorrow, using the login, you will get a brand new code. So don't forget to look for that. Don't try to use today's code. It will not work. That's it for me. Take care, everybody. See you tomorrow. All right.